that the patient needs an extensive workup. Shortness of breath is so morbid that there's no way that we're not getting that workup. And the truth is, whenever we hear the chief concern, often we're not thinking about what the answer is or should be. Often we're thinking about what do I need to do next to make progress. And so, in the evaluation of shortness of breath, you know you need to get an EKG, you know you need to get a chest X-ray, and you know you need to get a basic set of labs. And so often the questions in the history are less important because those tests are more specific to their related diagnoses. So I've asked myself over the years, what are the most valuable questions to ask in a patient who is short of breath? And this is a working hypothesis, and I'd love for people to chime in, but I can only think of 3 that are super high yield. The first is there any evidence of inflammation going on, such as fever, weight loss, cachexia, so on and so forth. The second is any evidence of heart failure like orthopnea, PND, etc. And the last is any evidence of presyncope. So somebody is short of breath, but they're also lightheaded. That's very helpful. So why are those 3 questions helpful? If there's any inflammation going on, I'm really worried about the pulmonary parenchyma. The lungs are way closer to the environment than the heart, and the pleura and the mediastinum are much more likely to be involved in an infectious process. MK, can I just jump in and clarify? Oh, can you make you? Okay, I'll make you co-host. Sorry about that. Okay, so why inflammation? Inflammation is much more likely to be pulmonary in origin. Why heart failure? One, if somebody has orthopnea and weight gain and lower extremity edema, the probability of heart failure skyrockets just with those questions alone. So here we had a patient who has shortness of breath, who has back pain, and who has malaise, and those have been going on for 2 weeks. The malaise is making me wonder whether that is an inflammation equivalent. That's what I'm really curious about. Is that malaise something that prioritizes an inflammatory syndrome? The key question will be, how does the back pain fit into this picture? And for clarity, back pain has to take a back seat. Why? Because malaise and shortness of breath are way more morbid than back pain. And most people who have shortness of breath and back pain just have a cause of shortness of breath exacerbating their chronic back pain. However, the connections between shortness of breath and back pain are extensive. You can have a pulmonary process erode into the back. This is why Pott's disease, TB of the spine, is notorious for causing a pulmonary and back syndrome, because the pulmonary focus of TB goes straight to the back. You can also have back pain actually be the manifestation of endocarditis, because it's actually really interesting pathophysiology, but microemboli go to the vertebral column and may cause symptoms well before the cardiac symptoms are apparent. So where am I at? I know this patient needs an evaluation for thoracic causes of shortness of breath. I'm worried that they might be inflamed based on the malaise. The back pain is taking a back seat because it often goes unexplained or exacerbated by idiopathic disease, but it may be connected through pulmonary disease directly working its way to the vertebral column, or less commonly, endocarditis involving the epidural space or osteo. All right, Franco, give us more.
Yeah, perfect. So this patient has a previous medical history of prostate cancer, was diagnosed 1 year prior to this presentation, and a recent diagnosis of end-stage renal disease due to the prostate cancer. So he was referred to the ER because he presented with 2 weeks of malaise, no irritating back pain that didn't change in nature for his baseline back pain due to the main problems of him, and 1 day of shortness of breath. He needed, in the ER note, it would say that he needed more fluid extraction during his last dialysis session due to an apparent fluid overload. He also had some previous medical history of tuberculosis at the age of 15 that was apparently fully treated. On the only meds that he's taking is occasional use of NSAIDs and antiandrogens because of the prostate cancer. Allergies known, the family history known. Social history, he lives in the Peruvian jungle and he's an agricultor. He engaged occasional drinking and smoked a pack of cigarettes per day.
Oh, amazing. Super helpful. Franco, can I ask, so just to clarify, he has chronic back pain that's unchanged
Yeah, it's chronic back pain, probably related to the prostate cancer.
Gotcha. So, a couple of things jump out. One, it's very unusual for prostate cancer to develop in a man in his 5th decade. It's possible, but it usually is age related, and the age cutoff is usually 60s, 70s and above. And so you might wonder, does this patient have two things? Does this patient have a prominent family history of prostate cancer? And or does he have a rare version of prostate cancer, which is not prostate adenocarcinoma, but rather a small cell prostate cancer? That's much less common. It usually occurs in people who have a long-standing androgen deprivation therapy, and it's different in that it usually is much more aggressive than prostate adenocarcinoma. It's also unusual to have end-stage renal disease from prostate cancer. Of course, patients can have bladder outlet obstruction and have chronic interstitial disease, but that connection is rare in many people and would push you to question whether this patient has another reason to have end-stage renal disease. So there are a lot of loose connections here. It's unusual that he has prostate cancer at this age. It's unusual that prostate cancer causes end-stage renal disease. But is that possible? Of course. And so we have to make sure that we don't assume that these things are 100% true, but they're probably good operating assumptions based on the fact that Franco presents them with so much confidence. But if you assume that they're true, you're probably now thinking, how does a patient with cancer, how can that influence the analysis of shortness of breath? And a patient with cancer, you have to think, do they have metastatic disease to their lungs? Do they have a pulmonary embolism? And do they have a pericardial effusion? Now, all those three things are rare with prostate cancer. Prostate cancer is hypercoagulable, but it doesn't usually go to the lungs, and it usually doesn't cause a pericardial effusion. The pericardial effusion hypothesis probably gets a little bit of credit from the presence of end-stage renal disease and uremic pericarditis. So what's different now? The thing that's different is the higher probability of a pulmonary embolism and the higher probability of a pericardial effusion. So what would I do differently? I think what has practically happened is, remember when we said a patient with shortness of breath needs an EKG, a troponin, a chest x-ray, and some labs? Now you've gone to the next tier. The chances of this patient needing a CT with contrast to look for pulmonary embolism, to look for a large pericardial effusion is much higher. So what happened practically? You can nerd out forever about the possibilities here, but this patient earned level 2 of dyspnea. Level 2 of dyspnea gets you a CT. So I think we're probably going to get there unless the answer is more apparent on the basic evaluation. Alrighty, Franco, please give us more.
I'm already enjoying this. So the temperature was 36 Celsius, heart rate 110, the blood pressure was 120/80, the respiratory rate was 22, and the SpO2 was 89 on 5 liters. Regarding the physical examination, generally he looked ill-appearing with increased respiratory effort, no adenopathies in the neck, the thyroid was non-palpable. Regarding the cardiovascular, the rhythm was regular. There was a pansystolic multifocal murmur. All the pulses were palpable. Pulmonary breathstones were diminished on 2/3 of the right hemithorax and the left was normal. The abdomen was distended with shifting dullness, non-painful. Neuro was normal, and regarding the extremities, there was bilateral leg edema and no rash.
Oh, Franco, this is amazing. You're presenting a case with a lot of water everywhere, a lot of volume. We don't know if it's hydrostatic, but we see that there's fluid in the belly. We see that there's fluid on the right side of the lungs, as evidenced by the dullness of percussion. And the question is this anything but transitate? And there's no reason to suspect that it is an exudative effusion. because it's on the right side, which is a common side for transitate, and the patient has no overt inflammation yet. But remember, we're dealing with a background of cancer, and the background of cancer can lead to an exudative effusion directly or through immunodeficiency causing an infection. But the working hypothesis should be that this is a transitive fluid until proven otherwise. And whenever we're in the world of transitive effusions, the question is it the heart, liver, or kidney? And here there's a signal for the kidney given the history and a signal for the heart given the murmur. And so the question is, which one is at play? A systolic murmur may be simply a flow murmur or a murmur related to anemia, which is a result of end-stage renal disease, but it being pansystolic and multifocal implicates the possibility of a pathologic murmur, which in this case should take us into the world of endocarditis because of the malaise and the shortness of breath. Remember, we put that hypothesis out very quickly in the presence of back pain, but also you have to think about the possibility of non-infectious endocarditis in a patient with cancer. So where are we now? I think remember, we have to anchor ourselves in the lay of the land. This patient is short of breath, and now we know that they're hypoxemic. And we also know that they likely have a large right-sided pleural effusion. And the mistake to make, I think, is to say, oh, okay, we're done. The large right-sided pleural effusion explains all of this. But that would be a mistake because most pleural effusions don't cause marked hypoxemia. The mechanism of a pleural effusion causing hypoxemia is through atelectasis, to compression of the lungs. But if somebody has a normally functioning contralateral lung, it's unusual for them to get this hypoxemic. So by virtue of how symptomatic the patient is, it's unusual for that pleural effusion to cause the symptoms. So where am I at? I'm no further off than worrying about something in the lungs, worrying about something in the heart with the murmur, worrying about a pulmonary embolism because of the cancer, and worrying about a pericardial effusion. But it's hard not to ignore the murmur. I think an X-ray and some basic labs and an EKG will tell us a lot. And so this is what Dr. Dhaliwal was telling us on Monday. You have to have multiple different operating hypotheses. What's the deal with the pleural effusion? What's the deal with the murmur? Why is the patient so hypoxemic? That's not fully explained yet. That's the foreground stuff. And the background that's still open is, how does a patient with end-stage renal disease, how does that change with a patient with end-stage renal disease? How does it change in a patient with prostate cancer? All right, Franco, back to you.
And I will give a lot of labs and some imaging. So regarding the white blood cell counts, the leukocytes were when in 11,000, no bands. It was a markedly predominant eosinophils of 1,500. The hemoglobin was 6. The MCV was low. The HCM was low. The hematocrit was 20. Platelets in the 300,000. The creatinine was 4.73. The BUN 48. Chloride 98. The potassium was 4.35. Sodium of 132. The hepatic function tests were kind of normal. A protein was 6. It was hypoalbuminemic with 2.7 of albumin, globulin 3.92. The procalcitonin was 2.4. The C-reactive protein was really high in the 324. It was COVID negative, HIV negative, hepatitis B and C negative. The PSA was above 1,000. There was also done a thorax CT that revealed only a severe right side pleural effusion with no apparent foci of metastasis. And I think I can give you the pleural fluid studies as well. The protein was 2, leukocytes on 400, 90% mononuclear. Red blood cells were on 4,000. The adenosine deaminase was on 22. And I can stop there.
Amazing. Franco, this is super helpful. Do you mind just summarizing the labs that you thought were key? Yeah, why don't you just go ahead and do that? Because I think there were a lot. So just tell us what the key labs were, just
Well,
while.
there was hypereosinophilia, there was a severe anemia that was
Yep.
with low MSV,
Yep.
and there is also a really high PSA.
Yep.
The pleural fluid diffusion was hematic, 4,000 of red blood cells, mononuclear predominant. And also, I think that, oh, it was HIV negative also. So I think those are the keys.
Amazing. That's super, super helpful. Sorry. I want to pull something up to show you all. Okay, there we go. All right. So I think all of us are shocked by the presence of eosinophilia. And when you see eosinophilia coupled with a microcytic anemia, it's hard not to immediately worry about the possibility of a parasitic disease that lives in the GI tract that has invaded. And that is a wise hypothesis, since infections are by far the most common cause of a significant eosinophilia. And the parasites that are in play are usually the migrating parasites, things like strongyloides, trichinosis, toxocara, paragonnomyces, which Valeria recently presented. And here we are in a similar situation where we have eosinophilia and a pleural effusion in a patient with Peru, and paragonnomyces is a very important consideration in that context. But this case has a lot more complexity because we have a patient with a PSA of over 1,000, which is the highest PSA I've ever heard of. And it's making me wonder, are there causes, because of how unusual it is to have disseminated prostate cancer in somebody this young? I'm wondering, hey, is this a fake out in any way, shape, or form? It's also interesting to see that the effusion is hemorrhagic, and that makes me wonder, wait, could that be simply because of the technique and that there was some hemorrhage along the way? But more likely, because of Franco's marvelous skills, we have to worry about other things. And here are some causes of a spontaneous bloody pleural effusion. We worry most about malignancy, and that's certainly in the background here. There's no evidence to think about coagulopathy, and there's no reason to suspect a catamenial issue here. There's no reason to suspect extramedullary hematopoiesis. We were worried about a pulmonary embolism well before, and now I think we have to think harder about it and ask Franco if the CT that was obtained was actually with contrast to look for a PE and to look for local vessel diseases. And the local vessel diseases you might invoke in the presence of eosinophilia is to remember that these parasites are angioinvasive. They literally get into the bloodstream and cause a lot of damage to blood vessels. And so I might wonder, is the eosinophilia the reason for the pleural bleeding? And does that take us somewhere else? By the way, I think Rafa, your screen is your Santa Strongyloides screen is pulling up right now. By the way, you have to explain, what does that mean? What's the Santa Strongyloides?
No, it's just there's a mnemonic in Brazil that we use to
Oh.
remember all the parasites that go to the
Really?
liver but are part of the
Cool.
intestines. Yeah.
Wait, is it in Portuguese?
Yeah, it's sometimes it's like holy in English.
Say that again.
It's Santa is a Portuguese word for holy.
Oh,
in
for
English.
holy. I see. Gotcha. Amazing. Yeah, well, we're looking at it now in real time. I love it. So where are we at? We are microcytic anemia and eosinophilia. And I think the easiest connection to make, you want to make sure that you're not assuming that that those are connected. The truth is that eosinophilia of this degree does a lot of damage to blood vessels. In fact, when you have eosinophilia this high, you want to make sure that there's no cardiac involvement. And that's when we go back to the murmur. The murmur here may be an example of non-infectious endocarditis. Now, hear me out. Non-infectious endocarditis means that there's damage to the heart valves that's not because of an infection directly. And that is often because of merantic endocarditis or through antiphospholipid antibody syndrome. But there's another way, and that other way is through hypereosinophilia. Now, hypereosinophilia can damage many blood vessels, including the heart, and cause eosinophilic myocarditis. And Shema is actually pointing out the mechanism. This is the mechanism for Loeffler's endocarditis. Loeffler's endocarditis is actually an as a fibrotic endomyocarditis, and that notoriously can be triggered by a variety of parasites and explain the murmur that we're seeing here. There's also a more chronic version of this called I think it's Darier's disease. It's basically a tropical endomyocardial fibrosis, where again, parasites are implicated in causing destructive and fibrotic disease to the heart. And acutely can look like a fulminant endomyocarditis and chronically can result in a restrictive cardiomyopathy. So where are we at now? The effusion is otherwise transitive. The protein is low, but it's bleeding. And you want to make sure that the bleeding is not a pulmonary embolism, but I'm worried that the unifying diagnosis here is a prostate cancer with a parallel process. And that parallel process might be a disseminated parasite. All right, Franco, give us more, please.
Great. I think I will give you a couple more of the studies, and I will reserve the final one after this discussion. So we did more extensive workup on the pleural fluid analysis. So it was negative for the bacilloscopy was negative. Also, it was negative for neoplastic cells. A biopsy also was taken over there. The CT didn't show like a pulmonary embolism. The echocardiogram didn't show like a vegetation. And after that, we turned out to do more research about those kind of infectious diseases. And the cryptococcal antigen came back positive. So we sent more analysis of the pleural fluid, and it was positive for Cryptococcus. And later on, the blood corpuscles also grew up Cryptococcus neoformans. So it was like a pleural effusion due to Cryptococcus in a patient with that advanced prostate cancer.
Oh my gosh, Franco, can you tell us what made you think to send the Cryptococcus? I would never have thought of that.
Well, because of the epidemiology of the patient, the Peruvian jungle is kind of where he standed was a big like epidemiological risk factor for invasive fungi and also Cryptococcus. He was like severe immunodepressed due to the cancer, probably, and the high level of the PCA. So when we have the negative results for tuberculosis and the negative results for neoplastic, we kind of search more regarding the epidemiology of the patient.
Wow, that's absolutely incredible. I completely out of left field for me. I never would have predicted that. Can you teach us what do you think of the eosinophilia? In your reading, did you come up on Cryptococcus triggering eosinophilia, or is that true and unrelated, or how does that fit into?
When we did a little review, the eosinophilia kind of fit in the diagnosis of an invasive cryptococcal disease, but it was most probably related to a paraneoplastic kind of thing of the prostate cancer that was really high. This patient had a really untreated prostate cancer. It was actually back in the jungle for a really long time before going to a healthcare center. So it was probably a really advanced case. After that, we started with the specific therapy for cryptococcal, and also the the PCA came down a little bit after that. So probably it could be like the disseminated cryptococcal also invade the prostate. We didn't manage to do a biopsy because we didn't find it necessary because it will be too invasive for this patient.
Wow, this is incredible. I'm so humbled by this case. It's not uncommon that something surprises you on VMR, but this is like a completely like 300, like 180 degrees for me. And I don't know if it's the same for the chat. What did before we go to Rafa to summarize the learning points, what did you take? Like, what do you think you can take away from this case that you'll apply to your reasoning going forward, Franco?
I think I can reflect on the other VMR that the ability of diagnosis is like you can have the most probability diagnosed, but you have to do a follow-up of another probability, and you have to think in both diagnoses at the same time. And if that didn't fall on the category of the most common, you can straight off and rethink about your schema. And in this case, the epidemiology and the place of the patient was key to finding the diagnosis.
Amazing. And you're saying that the epidemiology here is the Peruvian jungle where Cryptococcus is hyperendemic. Does that sound, that's fair?
Yeah, at least on that part of Peru.
Amazing. Wow. Just so humble. Thank you. All right, Santa, take it away.
This is so funny because Santa reminds me of Santa Claus.
I know,
Okay,
that's what I
so,
said.
but I swear to you that Santa is a word for Portuguese holy night, you know, like Santa. Okay, so back pain, we thought about malaise and shortness of breath, and then we have to prioritize those in the setting of because they have more morbidity. And then we try to combine the pulmonary and the back pain. We thought about Pott's disease, which is a complication of TB, but also in the carditis manifestations with those microemboli. And we have to think that when we're dealing with patients with back pain, most of them actually have benign disease, but there are certain red flags that you should consider. For example, age greater than 50, history of cancer, constitutional symptoms like fever and weight loss, no response to previous therapy, nighttime interfering with pain. We see that especially in the setting of malignancy, but also neurological deficits. And then we try to combine the cancer and the shortness of breath. And the Rabbi Reza always teaches us that shortness of breath, 95% of the causes are actually cardiopulmonary in nature. And we have to think like, what could, in the setting of cancer, lead to cardiopulmonary manifestations? And we thought about metastasis to the lungs, pulmonary embolism, just the hypercoagulability that we see in patients with malignancy, but also pericardial effusion. And then we saw that this patient had edema on the physical exam. And Rabbi always teaches us to think about the kidney, especially if these patients have like periorbital edema in the morning, or the heart, like elevated JVP, pulmonary crackles, the liver, there's any jaundice, spiroangioma, pulmonary erythema. And then when it comes to the eosinophilia and lungs, we have to remember that some parasites have the lungs as part of their life cycle, even though the adults live in the intestine. And there's pneumonia in Portuguese that we use, Santa. It stands for strongyloides, ascaris, necator, toxocara, and celostoma. And that leads to eosinophils in the lungs. So these patients can have wheeze, shortness of breath, and fever. And finally, the final diagnosis was cryptococcus, something that we didn't think of, because when you're dealing with infectious disease, we have to keep in mind epidemiology is very common in Peru. So people from there thought about this disease, thankfully. And it's something that we don't tend to think about it in the setting because this is commonly associated with meningitis with elevated intracranial pressure due to physical obstruction by the capsule. So thank you, everyone. Such an educational case. I hope everyone had fun and learned something today, and I hope to see everyone tomorrow.
Absolutely superb. Thank you for a wonderful case, Franco, and a marvelous summary. And thank you to Anne Marie and Kelty for scribing. I'm not sure who was driving the reins, but I appreciate both of you jumping in and helping out. All right, y'all. I'm gonna go nerd out forever about Cryptococcus. This is very, very humbling. Franco, if you can tell us at some point, whenever you're back, what you think about the hemorrhage, how that marries, and if you know now, go ahead and tell us, or maybe later, because that's another completely, I don't know where that came from.
I will dig more into it.
Okay, perfect. All righty, y'all. Take care, okay? Bye.